All right. Bismillah. So good morning. Can you hear me clearly?
Yes, we do.
Yes, doctor.
Yes.
All right.
Yes, doctor.
All right. So today we'll be talking about this pulmonary function test, as you see here. And inshallah, in the afternoon, we are going to do this lab on this spirometry. So objective of this lecture today is to identify the significance of the pulmonary function test. What is the significance of doing this? And also the main concept of different pulmonary function test, because it could be either static or dynamic. And describe the spirometer and identify different pulmonary function tests not measured by it. So we cannot measure everything by the spirometry. So we will talk about those things. So, so pulmonary function test, what is this? So these are the tests. So to evaluate the function of the respiratory system. So test to evaluate the function of the respiratory system. What are the indications for doing this? What are the indications when we should do the pulmonary function test? If we want to detect lung disease, either obstructive or restrictive. So you know now there is two kinds of lung disease. Mainly we can classify obstructive and restrictive, so we can detect. To evaluate the extent or monitor the course of the disease, and to evaluate the treatment with bronchodilators. So these are the indications. There are many other indications, but here we are talking about these three. So indication here is more explained here. Indication for the pulmonary function test, as you see, number one, investigation of patient with symptoms, sign, investigation that suggests pulmonary disease. So you did some other investigation that suggested that this patient might have pulmonary disease. So what are the signs and symptoms? For example, cough, wheeze, breathlessness, crackles, abnormal chest X-ray. If you find this thing in the investigation, so you can do the pulmonary function test. Number two, monitoring the patient with known pulmonary disease for prognosis and response to treatment. So known disease, known person has the pulmonary disease. So now you want to see the progression and response to treatment. For example, in interstitial fibrosis, COPD, asthma, pulmonary vascular disease. Okay. Number three, investigation of patient with disease that may have a respiratory complication. Many disease has respiratory complications. For example, connective tissue disorders, neuromuscular disease. Number four, pre-operative evaluation prior to, so pre-operative evaluation prior to your big surgery. So before these big surgeries, pre-operative evaluation is done by doing this pulmonary function test. Number five, evaluation of the patient, a risk of lung disease. Well, the risk of lung disease, for example, exposure to pulmonary toxins such as radiation, many medications, environmental or occupational exposure. And number six, surveillance following lung transplantation to assess for rejection, acute rejections, infection, or obliterative bronchiolitis. So these are the indication for the pulmonary function test. Any questions from here?
It's clear.
Is okay? All right. So what are the factors that will affect the respiratory functions? So many factors can affect the respiratory capacities. These are the normal variations. For example, age, old age or very young, sex, for example, male and female, person's height and weight, physical condition, position during the test. All these factors will affect the respiratory function. These are the normal variations. Okay, so pulmonary function test, as we told at the beginning, so there is a static test, static, and dynamic. Okay, so in the static test, we see all the lung volumes, lung capacities, dead space, pulmonary ventilation. In the dynamic state, you could see the peak expiratory flow rate, PEFR, peak expiratory flow rate, timed vital capacity, maximum breathing capacity. So these are the dynamic tests, and these are the static tests. So what is the apparatus for doing the pulmonary function test? It's called spirometer. Spirometer. And this process is called spirometry. Spirometry. So there are many other pulmonary function tests, but today we are talking mainly about the spirometer. So there is a picture of 3 different types of spirometer. In our lab, we have this one. We have this one and also this one, but we don't have this one. These are in the hospital setting, they have it. But in our lab today, we'll be using this spirometer for doing the pulmonary function test. So pulmonary function test, so what we see in the pulmonary function test, we can see the lung volumes and lung capacities. As by this time, you all know there are 4 lung volumes, 4 lung volumes and 4 lung capacities. Okay. Tidal volume. What is the tidal volume? Tidal volume, the volume of air inspired or expired per breath during rest. In the resting condition, you don't even feel it. In the resting condition, the volume of air goes in and out per breath is called the tidal volume. This is one of the volume. Number 2 volume is the inspiratory reserve volume, IRV. What is this? Maximal volume of air inspired after normal inspiration. This is about 3000 ml. So tidal volume is about 500 ml and IRV is about 3000 ml. Number 3, expiratory reserve volume, ERV. What is that? Maximum volume of air expired after normal expiration. So this is about 1000 ml. The last one is residual volume, residual, RV, the volume of air remaining in the lung after maximum expiration. That is about 1200 ml. So these are the 4 volume. There is another term here, it's called the minimal air. What is that? It is 5 ml of air, 5 milliliter of air that enter the lung with the first breath. When the baby is born, after the baby is born, the first breath that he or she take, it's about 5 ml. It never leaves the lung even after death. It still stays there. It is of the medical legal importance. We can explain that later if you ask me. This is the minimal air. Okay. So 4 lung volumes. This is the picture of the lung volumes. As you see here. So this one is the tidal volume, TV. So what is this? Volume of air inspired and expired during normal quiet breathing. This is the tidal volume. Second one, IRV, inspiratory reserve volume. This is the inspiratory reserve volume, IRV. So maximum amount of air that can be inhaled from the resting end of the inspiratory level. So from here up to this is the IRV. What is ERV? This is, you see, ERV. So maximum amount of air that can be exhaled after normal tidal expiration. So this is the ERV. Residual volume is the residual volume. So volume of air remain in the lung at the end of maximum expiration. It never leaves, so it's remain in the lung. So these are the 4 lung volumes. Any questions about the lung volumes? Okay. So about this minimal air that we talked. So what is the minimal air? It is the volume of air remaining in the lung after opening the chest and expelling the residual volume. It is the air that enters the lung with the first breath. When the baby takes the first breathing, that is the minimal air. What is the medical legal importance? This will determine whether the newborn was born live or dead. The baby who was born, when he was born, he was alive or dead. How? If a piece of the lung, if you take the piece of the lung from the baby, if a piece of the lung floats in the water, minimal air is present. That means the infant respired, then died. So infant took the breath and then he died. Okay. And if it does not float, if this piece of lung does not float, that means infant was born dead. You see how you can differentiate the baby who died after death, who was alive when he was born or dead. So you can differentiate in this way. It's clear?
Can you repeat this point, Doctor?
Okay. So this minimal air, what is the minimal air? It is the air that enters the lung with the first breath when the baby is born. So if you want to see, okay, and after that, maybe baby died. So how do you determine the baby who was born, if he was born alive or dead? So you do the autopsy, you cut the chest, take a piece of the lung, and if the piece of the lung floats in the water, if it is floating, that means minimal air is present. That indicate the infant take a breath, after that he died. If the lung does not float, that means the infant born was dead. He was born dead. He didn't take any breath. Is it okay?
Yes, thank you.
All right. So we know the lung volumes. So similarly, there are 4 lung capacities. What are the lung capacities? This slide is little, you cannot see properly, so I'll go here. So vital capacity, you see, so these are the volumes, 4 volumes. and these are the 4 capacity. So this is the VC or vital capacity. So what is vital capacity? Volume of air that can be exhaled from the lung after maximum inspiration. So you take a deep breath and you breathe out everything. So that is called the vital capacity or VC. So there is a FVC, forced vital capacity, FVC, because you will see this term, FVC. What is FVC? Total volume of air that can be exhaled forcefully. That is called the forced vital capacity. And another one is the SVC, slow vital capacity. When the vital capacity is exhaled slowly. Okay. So vital capacity is the combination of the combination of IRV, TV, ERV. These 3 volume together is the vital capacity. Is it okay? Vital capacity. The next one. Yes. Okay. Any question? Any questions? Okay. Inspiratory capacity. What is that? Inspiratory capacity. You see this IRV plus TV. Maximum amount of air that can be inhaled from the resting expiratory level. Inspiratory capacity, from the name, how much air you can inspire. How much you can inspire. You see, total IRV plus TB, maximum amount you can inspire. Functional residual capacity, this FRC. FRC, what is that? Volume of air remaining in the lung at the end of the expiration. So at the end of the expiration, volume of air that remains in the lung, FRC. FRC is ERV plus RV, ERV plus RV. What is total lung capacity? Total lung capacity, as you see, is the combination of everything, TLC. Volume of air in the lung at the end of maximum expiration, volume of air in the lung, total volume. So it is the combination of all 4 volumes. So these are the 4 capacities and 4 volumes we know now.
Doctor, I have a question.
Yes, please.
So is RV always will be 5 milli?
5, yeah, is the you're talking about the minimal air?
Yes, just like we took the first breath.
Yeah. Usually the 5 mL. It could be, depending on the size of the baby and also the body position and everything, it could be a little more. Okay. All right. So what are the factors that affect the vital capacity? Okay, so you see, these are the physiological factors. Posture. So vital capacity will be more in standing and sitting than in the recumbent position due to the compression of the diaphragm. So more in the standing and sitting. Sex, it is more in male than in female. In the male is 4,600, in the female is 4,200. Body build, it is more in lean than in the obese person. Muscular exercise, it is more in athletes than non-athletes. Pregnancy, it is less in pregnant than non-pregnant. These are the physiological factors. How about the pathological factors? Vital capacity is decreased in restrictive lung disease and obstructive lung disease. Okay, so restrictive lung disease, as in the pulmonary congestion, pulmonary fibrosis, diaphragmatic movement, So this causes the decrease in the vital capacity. In the obstructive lung disease, for example, in bronchitis, bronchial asthma, emphysema, all can cause decrease. So we know these 4 volumes and 4 capacity, which can, some of the volume and capacity cannot be measured by spirometer. What are those? For example, residual volume, we cannot measure. Functional residual capacity, we cannot measure. Total lung capacity, we cannot measure with this spirometer. Okay, so what is the significance of residual volume? Residual volume, what is the significance? It provides the air for the gas exchange between with the blood and the breath. So because this amount of air is remaining in the lung all the time, so this will facilitate the gas exchange with each breath. So pulmonary ventilation versus alveolar ventilation. Pulmonary ventilation versus alveolar ventilation. So minute respiratory volume, MRV, and effective pulmonary ventilation. What is the difference? Let's see here. So what is pulmonary ventilation? The total amount of air that moves into the respiratory tract per minute. The total amount of air that moves into the respiratory tract per minute. It is equal to respiratory rate times tidal volume. So for example, respiratory rate is 12 per minute. So 12 and tidal volume is 500. So 12 times 500 is 6 liter per minute. This is the pulmonary ventilation. So what is alveolar ventilation? What is the difference? So it is the volume of air that enters the alveoli. So enters the alveoli, but the gas exchange is happening, right? And that can undergo gas exchange with the pulmonary capillaries. What is that amount? It is the respiratory rate times tidal volume minus dead space. Because the dead space, in this space, the air, they are staying in the dead space, starting from the nose until the bronchioles. They do not take part in the gas exchange. It's about 150 ml. So 500 minus 150 is 350 times 12 is about 4.2 liter per minute. So you see there's a difference between the pulmonary ventilation and alveolar ventilation. Any questions? So dynamic test. What is the dynamic test as we talk? So one of the dynamic tests is the peak expiratory flow rate, PEFR. You see, PEFR. So with this, so this is the PEFR. So very simple apparatus. So you take a deep breath and put the mouthpiece into the mouth and blow as hard as possible. And there is I'll show you in the lab today. And you take the 3 reading from this test, and you do the average or take the highest reading. What is the importance of this PEFR? The apparatus is simple and portable, very simple apparatus. It is very useful in mass survey of the lung function. It is used as a screening test in suspected obstructive airway disease. Okay. You see, this is the peak flow meter. This is the machine. This is the peak flow meter. And the peak expiratory flow rate, this is the chart, or you can see roughly. So these are the A's in years, and this is the body height in meters. and you can see what will be your predicted PEFR. For example, you are 20 years old and your height is 170. So it will be around 573. This is the roughly. So roughly we can say height minus 80 times 5 liter per minute. That is your PEFR. Now we'll be talking about this timed vital capacity. We know the vital capacity, but we will time it. So forced expiratory volume in the first second. Forced expiratory volume in first second. FEV on. Forced expiratory volume in 1 second. What is that? It is the maximum volume of air that can be expired when the subject tries as forcefully and rapidly as possible after maximal inspiration. Okay. It is the measurement of the vital capacity over unit time. Okay. Forced vital capacity is normally equal to the static vital capacity. What is the procedure? The person first will inspire maximally, take a deep breath to the total lung capacity and exhale into the spirometer with maximum expiratory effort. So you take a deep breath and then breathe out as forcefully and as maximum possible. So here it is, FEV on over FVC ratio. So you see, so this is the FEV on seconds. FEV on means on second. This is in 2 seconds, and this is in 3 seconds. So as you see here, so this is the volume of the air. So from 0 to 6 liter. And this is the time, 0 to 4 seconds. You see in 1 second, about 83% of the air is expired, 83%, FEV1. FEV2, almost 93% is gone. 97% after 3 seconds. So this is the ratio. So in obstructive and restrictive lung disease, what happens? So this is the normal lung. This volume is in the normal lung. So FEV on is here. Okay. In the restrictive lung disease, as you see here, in the restrictive lung disease, this is decreased. And in obstructive lung disease, this is also further decreased. But how about the ratio? This ratio I'll show you in the next slide. This one is the flow volume loop. This is the loop. So today, inshallah, we'll do this today. So what is this? So from 0 here up to 8. So this is the flow. When you're blowing, how many liters is going per second? For example, this one is peak expiratory flow rate. It's almost 8 liter per second. So this is the expiration, and this part is called the inspiration. So inspiration and expiration. This is a loop. This is called the flow volume loop. Okay. As you see from here, 0 to 6 liter. So this is the total lung capacity. 0 to 6 liter is the total lung capacity. So this is the loop. What happens to the loop in different lung condition? This is a normal loop. Inspiratory flow, expiratory flow. In the obstructive lung disease, what you see? Inspiration is no problem. Inspiration is same. but expiratory flow is decreased. Expiration is decreased. In the restrictive lung disease, you see here, both are decreased, both inspiration and expiration is decreased. So in the obstructive lung disease, expiratory flow is decreased. In restrictive lung disease, both inspiration and expiration is decreased. Maximum breathing capacity. What is that? Maximum breathing capacity and maximum voluntary ventilation. It is the maximum volume of air that can be breathed per minute with voluntary effort. Okay. So you will ask the patient to breathe as fast as possible and as deep as possible for 15 seconds. As fast and as deep for 15 seconds. Then multiply by 4 to see the volume in 1 minute. You're doing this 15 seconds and multiply by 4. You see the volume in 1 minute. Normally, MBC is 80 to 160 liter per minute in male. In female, 60 to 120 liter per minute. So what is MVV? Is a test of the entire respiratory system. Okay, maximum voluntary ventilation. MVV may be obtained by multiplying the MVV by 3.35. So this is the test for the entire respiratory system. So here is the chart for difference between the obstructive and restrictive lung disease. Obstructive, restrictive. So forced vital capacity, FVC. In the obstructive, it could be normal or decreased. In the restrictive, it is decreased. FEV on, obstructive, decreased. In the restrictive, also decreased. FEF, obstructive decreased, in the restrictive normal or decreased. The ratio, this is the important one, FEV on over FVC. In the obstructive, it is decreased. In the restrictive, it could be normal or increased. And PFR, this is decreased. And this could be normal to decreased. So this is all the lectures, but I want to show you a video. Okay, stay with me.
Spirometry is a common test for lung function. It is used to diagnose asthma, COPD, pulmonary fibrosis, and other lung diseases. It can also be a helpful tool to monitor disease progression and evaluate effectiveness of a treatment plan. A tube-like device called a spirometer is used to capture and record air volumes and breathing speed. A spirometry test typically reports 4 respiratory volumes: tidal volume, TV, the amount of air inhaled or exhaled during normal, quiet breathing without effort. Inspiratory reserve volume, IRV, the amount of air that can be inhaled with maximum effort after a quiet inhalation. Expiratory reserve volume, ERV, the amount of air that can be exhaled with maximum effort after a quiet exhalation. Residual volume, RV, the amount of air remaining in the lungs after a maximum exhalation. These volumes are used to calculate other parameters called respiratory capacities. Inspiratory capacity, IC, the maximum amount of air that can be inhaled after a quiet exhalation. Functional residual capacity, FRC, the amount of air remaining in the lungs after a quiet exhalation. Total lung capacity, TLC, and vital capacity, VC. the amount of air that can be exhaled with maximum effort after a maximum inhalation. This is basically the volume of the deepest breath the lungs can possibly handle, and is an important indicator of pulmonary function, as well as strength of respiratory muscles. Vital capacity can be measured as slow vital capacity during slow, relaxed breathing, or as forced vital capacity, FVC, when the patient is asked to breathe out as hard and fast as possible. While there is little or no difference between these two values in healthy individuals, people with difficulty exhaling usually show significantly lower FVC. Another important parameter obtained during forced spirometry is the forced expiratory volume, FEV1, the amount of air that is exhaled during the first second of forceful exhalation, after a full inhalation. FEV1 is used to calculate the percentage of air that is expelled during the first second. This FEV1 over FVC ratio inversely reflects the resistance to expiratory airflow. In healthy people, it is around 70 to 85%. A smaller number means increased lung resistance. Spirometry is useful in differentiating between restrictive and obstructive pulmonary diseases. Restrictive lung diseases can be inspiratory or expiratory. Inspiratory restrictive are conditions in which lung compliance is reduced, limiting lung expansion when inhaling. This can happen either because the lungs become stiff as a result of scarring or fibrosis within lung tissues, or the respiratory muscles are too weak to inflate the lungs. Expiratory restrictive is when exhalation volume is limited due to weakness of accessory muscles involved in deep exhalation. Restrictive lung diseases are associated with decreased lung volumes, or total lung capacity, TLC. Obstructive lung diseases, such as asthma or COPD, on the other hand, show a normal or somewhat increased total lung capacity, TLC. This is because the obstruction increases lung resistance, making breathing out harder and slower, and this results in increased residual lung volume. Vital capacity remains normal during quiet breathing, but when breathing rapidly, a higher pressure is required to overcome the increased resistance, and forced vital capacity is reduced. A more reliable indicator of obstructive lung disease, however, is the lower percentage of air that is exhaled during the first second of forceful exhalation.
In this video, we're going to look at spirometry and look at the differences between normal, obstructive pulmonary disease, and also restrictive lung disease. It is a good idea to recap the lung volumes and lung capacities before looking into this video. So one way to monitor lung function is by using a lung function test, such as a spirometry. If we breathe in and out normally in this lung volume measuring device, we can see our tidal volume, which is typically 500 mils or 0.5 liters. The graph here, the x-axis you can say is just the time, and on the y-axis is the lung volume. So going up the y-axis is inspiration. The lung volume will increase when we inspire air in. And going down the y-axis is expiration. The lung volume will decrease when we breathe out, obviously. So now imagine taking a maximal deep breath in. This is the inspiratory reserve volume, also known as IRV. And now imagine taking a normal breath or normal breaths and then having a maximal expiration. This is your expiratory reserve volume, or ERV. And the air remaining in your lungs after the maximal expiration is the residual volume, or RV. You just always have that there. Using these lung volumes, you can measure the lung capacities. The lung capacities help define functioning lungs. The vital lung capacity refers to the maximum amount of air expired from a fully inflated lung. This means it's the tidal volume, TV, plus the inspiratory reserve volume plus the expiratory reserve volume. The functional residual capacity, which should not be mixed up with the residual volume, represents the volume of air remaining in the lungs after expiration of a normal breath. So it's residual volume plus expiratory reserve volume. Very important is also the total lung capacity, which is the sum of all the lung volumes. In a typical adult male, it's about 6 liters. We will use a typical adult male total lung capacity as an example in the following scenarios. So this first graph represents a normal lung. Air coming in and carbon dioxide coming out. The alveoli are inflating and deflating normally. Dynamic measurements of lung volumes and capacities have been used to help determine lung dysfunction. The vital capacity is really important to remember. Again, it's the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. The forced vital capacity is basically the same thing as the vital capacity, but by definition, it is the largest amount of air that can be expired after a maximal inspiratory effort. So you breathe very deep in, and then you breathe out fully. The forced vital capacity is frequently measured clinically as an index of pulmonary function. It gives useful information about the strength of the respiratory muscles and other aspects of pulmonary function. Let us draw it in a graph of a normal lung. Here you have the volume on the x-axis and flow through the lung on the y. So a normal adult has a total lung capacity of 6 liters. So here is the volume set here at 6 liters. So from 0 to 6 is the total lung capacity. The forced vital capacity, FVC, is again the largest amount of air that can be expired after you take the maximal breath in. The spirometry helps document and measure all this. So imagine taking a deep breath in and then exhaling it out as forcefully and as quickly as you can. We can thus say this is your vital capacity or forced vital capacity, which in reality is your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume. Thus, the remaining air in our lungs after a maximal expiration, if you remember, is your residual volume. We can look at the forced vital capacity on a different graph by also introducing time. When we introduce time, we can calculate another component. Here we are looking at time on the x-axis in seconds, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then on the y-axis is the volume of air in the lungs in liters, so 3 liters here and 6 liters. Remember, 6 liters is the total lung capacity in an adult male. Here is the volume of air expired by a normal adult man during a forced expiration after a deep inspiration, which again is your forced vital capacity. And here it's about 5 liters. And this again is your forced vital capacity. Thus, again, the air volume remaining in the lungs after maximal forced expiration is your residual volume. Now, this is an important concept. See if you can follow. The fraction of the vital capacity expired during the first second of a forced expiration is referred to as the forced expiratory volume, or FEV1. So from the graph, the forced expiratory volume in the first second FEV1 to the forced vital capacity FVC ratio can be calculated. 4 liters divided by 5 liters, which is 0.8 or 80%. And again, this is normal. We will look at how this changes with certain diseases. So let's look at what happens in COPD, where we have gas trapping and we have obstruction of the airways. Many changes are seen in lung volume and lung capacities. In obstructive airway disease, straight away we can see an increase in total lung capacity. This is why it is common to see features of an enlarged chest in patients with COPD. The tidal volume remains the same. However, the inspiratory reserve volume decreases, the expiratory reserve volume increases, and the residual volume increases as well. Thus, if we were to calculate the lung capacities, the vital capacity, or also we can straight away say the forced vital capacity, is the same or maybe decreased. The functional residual capacity is increased, and the total lung capacity, as mentioned, altogether increases. The reason behind these changes in lung volume and capacities are two main things. Firstly, the reduction in airflow to the lungs due to obstruction. And then you have what's called air trapping. The air remains in the lungs at expiration. As a consequence, you get hyperinflation and consequently an increase in your functional residual capacity. Now let's see this using a spirometry and compare it to the normal on the left side. Again, here we have the graph with volume in liters on the x-axis and flow of air through the lungs on the y-axis. The forced vital capacity, FVC, again, is the largest amount of air that can be expired after maximal inspiratory effort. Here in the dotted black line is normal forced vital capacity, normal full inspiration, and then normal full expiration. And this is obstructive lung disease. The whole graph shifts to the left because you have an increase in residual volume and an increase in total lung capacity, more than 6 liters. Your vital capacity, or forced vital capacity you can say, remains the same. But all up, your total lung capacity has increased because of the increase in your residual volume, or better, because of the increase in your functional residual capacity. You can see here the characteristic kink in the obstructive lung disease patient during forced expiration. This is because of the obstruction. And also the flow decreases slightly because of the obstruction through the airways. Let's see what the first second of a forced expiration is using the graph, looking at time and volume on the y-axis. Again, to compare this to normal forced vital capacity, this is obstructive lung disease. We can see that the forced vital capacity is the same or slightly decreased. The forced expiratory volume in the first second has dropped significantly. Obstructive lung disease can be diagnosed when the ratio between FEV1 and FVC is less than 0.7 or 70%. And so in this example, FEV1 is about 1 liter and the FVC is about 5 liters. And so 1 divided by 5 is obviously less than 0.7 or less than 70%. And thus, this is an example of a person who has obstructive lung disease. Finally, let's look at restrictive lung disease. These conditions include pneumoconiosis, sarcoidosis, amongst many other things. In restrictive lung disease, you have restriction like fibrosis in the lungs, which impair lung compliance. So the tidal volume remains the same, but you have all this restriction in the lung, all this fibrosis. And so your inspiratory reserve volume is reduced and your expiratory reserve volume is reduced and your residual volume is reduced as well. Everything is reduced. Thus, your forced vital capacity is reduced. The functional residual capacity is reduced, and surprisingly, your total lung capacity is reduced. The reason for this again is because of pulmonary fibrosis or changes in the lungs that lead to restriction and lung compliance. You get stiffness, restriction, and because of this stiffness, you have reduction in lung volumes and lung capacities. Let's look at your forced vital capacity using a graph again. The dotted black line represents normal forced vital capacity, which is the largest amount of air that can be expired after a maximal inspiratory effort. Here in brown is the pattern of forced vital capacity seen in restrictive lung disease. As you can see, it has shifted to the right. The reason for this shift and change is because firstly, your total lung capacity has reduced because of the restrictive lung changes. The residual volume has reduced, and so it is no surprise your vital capacity or forced vital capacity is reduced. What about the forced expiratory volume in the first second? Well, let's look at the other graph again at time on the x-axis. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds. And lung volume on the y, which again in a normal adult male goes up to 6 liters. A normal person shoots up and the forced vital capacity goes up to about 5 liters. In restrictive here, however, in brown, you can see that the forced vital capacity has reduced dramatically. But the forced expiratory volume in 1 second is not as affected. The forced expiratory volume in 1 second, FEV1, in restrictive lung disease is not as affected as seen in patients who have COPD or obstructive lung disease. It can be normal actually in these patients who have restrictive lung disease or reduced, depending on the severity and if the person has obstructive lung disease too. The FEV1 to FVC ratio is a useful tool in recognizing severity of airway disease and can help differentiate between COPD and restrictive lung disease. In restrictive lung disease, the FEV to FVC ratio is not as affected. So for example, in this scenario of restrictive lung disease, the FEV1 is about 3 liters and the forced vital capacity is about 4 liters. So 3 divided by 4 is 0.75 or 75%. And thus, this can constitute restrictive lung disease rather than obstructive airway disease. Hope this video makes sense and hope it was helpful.
This for the obstructive and restrictive lung disease. What is the ratio FEV1 over FVC in obstructive and restrictive? Anybody there?
Obstructive is lower than 80.
The ratio FEV1 over FVC is lower than 70%.
Yep.
And how about the restrictive?
The restrictive is the same.
Yeah, it could be same. It could be normal. But because both are decreased, FEV1 and FVC both are decreased, so the ratio remain the normal. But in obstructive, FEV1 is much more reduced than the FVC. That's why the ratio is very low. Okay, so any more questions?
Doctor, you said that the minimal air never leaves the lungs. Is there any explanation for this?
So this is very minimal air, only 5 mLs. So as hard as you, these are trapped inside the alveoli. It can never leave. This is the explanation. This is so minimal that whatever you do, you cannot expel this. So it will stay there lifelong.
Okay, thank you.
No problem. Any more questions? All right, if no questions, so we'll stop it here. Inshallah, I'll see you in the lab from 1 o'clock. All right. Thank you very much.
Thank you.
Salam alaikum.